everybody's sitting around waiting for the federal government to do something, you know. But if you actually look around the country, there's a pay-for-performance program everywhere in America now, except for Medicare. They're still thinking about it. They just announced yesterday their final regulations to do that for hospitals. Medical home programs here and everywhere. Medicare only just got into medical homes a few months ago. Episode payments, global payments are being done in various places around the country, way ahead of the federal government. So the question is, why are we waiting for the federal government to do anything? This actually can be done at the community level. Now, you have to have measurement to be able to support payment, not just to support the way physicians function, but the way the payment system works. Because the concern that you should all have is that, well, if all of a sudden my doctor and hospital is trying to save money, how do I know that they're not keeping things away from me that I need? Now, we know that the current fee-for-service system is ideal in achieving maximum quality in healthcare. Anything that we do to move away from it, we probably heard that, but what you do is you say, let's measure quality, and let's make sure that, in fact, the folks who are doing this kind of payment are doing high-quality care. And we have a lot better systems in place now to be able to measure quality than we did 10 or 20 years ago. Still a long way to go, but much better. The question that communities have to face is, who should actually do this measurement? Should it be done by the federal government? Or should you actually try to do it at the community level where physicians and hospitals and patients can be engaged in making sure that it works well? And what is happening in a number of communities around the country is that this kind of quality measurement is being done at the community level so that they can figure out what needs to be measured, how to measure it, etc. And that's really where a lot of the innovation in quality measurement is coming from right now. Now, it's not just the payment method, it's also the right price. Because I can structure all the incentives the right way, but if you pay too much, you're not saving any money. If you pay too little, doctors and hospitals can't deliver good quality care and may end up having going bankrupt. Now, the thing that will surprise you, potentially, is that the price for warranty care is likely going to be higher than the price of care today. Right now, this sounds like a really strange thing, particularly if you're paying for healthcare, because you say, I'm already paying enough for healthcare, why would I pay more? But think about it. In every other industry, every other product that you buy, you would expect to pay more for a product with a warranty than a product without a warranty. Why? Because you would say, I know I'm not going to have to pay separately for all those repairs and replacements that I might have to do. So the question is it the right price? But I would expect to pay more. So in healthcare, hospitals get paid by, for example, diagnosis-related groups. You would have to have a higher price for that with a warranty than without. Let me give you an example. I hope you can see this in the back. $10,000 procedure, sort of this hypothetical $10,000 procedure. And 5% of the time today, the patients are getting an infection. And it costs $20,000 to treat those infections every time they occur. So today, on average, the health plan is not paying $10,000 for these procedures. They're actually paying $11,000 for these procedures. Because they pay $10,000 when it goes well, and they pay an extra $20,000 5% of the time. So if you were a physician or a hospital and you wanted to say, I'm going to now give a warranty on this procedure, I'm not going to charge any more for infections whenever they occur, how much would the price be? What price would you set for warranty on this procedure? Well, the answer is, you'd say, I'd start with $11,000. Because if I charge $11,000 per procedure and I don't charge any more whenever there's infection, I make exactly the same amount of money I'm making today. But the interesting thing is all the incentives suddenly change. Because now, if I can reduce the infection rate down to 4%, I'll reduce my costs because I no longer have to treat those infections. But I'm still making the same amount of money. I still get the same revenue. So I actually make more money by giving better quality. But we want to save a little bit of money in healthcare, right? So this provider can now say, I'll offer this procedure now for $10,800. And maybe some health plans or local employers will actually send me more patients because I deliver now higher quality care at a lower cost. And the incentive continues because if I keep driving the infection rate down, I keep reducing costs, but I end up making more money. And in the end, what do I end up with? zero on the infections as I possibly can. So quality is better, the patients are better off. The cost is lower because I used to spend $11,000 on average. Now I'm only spending, under my little hypothetical example, $10,600. And the provider is making more money. Win, win, win. Patients are better off, payers are better off, providers are better off, if you change the payment model. Now this is completely different than if you were to say, let's just not pay the hospital, the doctor, for infections. Because in the short run, until they figure out how to get rid of those infections, you're making them lose money. And with hospitals having very narrow margins, that is a very dangerous thing to do, to be able to do that. So the warranty approach with a price that's appropriate, it gives them the incentive and the ability to actually reduce that. But this gets back to the data issue. You got to have data that both sides of the table can look at and trust. So the hospital and the doctor have to know what is their current infection rate, how much does it cost to treat those infections, and how would we price this warranty. The health plan or the employer who's paying for this has to look at that and say, am I getting a better deal? Is that price that they're offering me a better deal than I'm getting today? And they have to agree so that you're not sitting and fighting on the data. The other thing that you have to think about is, people are going to have to take time to be able to evolve into this new system. So the payment systems and the provider systems need a little time to evolve. They don't just suddenly move from where they are today into these new kinds of structures. So let me give you an example. So I mentioned the issue of hospitalizations. We actually know how to reduce hospitalizations for chronic disease patients dramatically. Been done over and over and over again. Again, not little itsy-bitsy reductions, but 20, 40, 60% reductions through doing very simple things. Better patient education, helping patients understand their medications, how to manage their conditions, telemonitoring to try to identify problems early on. The problem is we don't pay for those things. Every time one of those projects has been done, it's been successful, and then it immediately gets stopped because everybody loses money for doing it. So this is my picture of how the current healthcare payment system works. We pay for office visits. We don't pay for phone calls. We don't pay for nurses. If you ever wondered why it's hard to get your doctor on the phone, because the doctor doesn't get paid to answer the phone. They only get paid whenever you come into the office. But every time you show up in the ER, every time you show up in the hospital, every time you get an extra lab test, it gets paid for. Is it any wonder we have high rates of hospitalizations and ER visits? Now, the notion of the comprehensive care global payment can fix that. Because if you give a physician practice or a provider system one single payment to manage condition, they can decide, is it better to answer the phone, do an office visit, send a nurse out to see you, if you think it will save money. But that's a big jump from where we are today in terms of the fee-for-service structure. So we need transitions. We need ways to help physicians be able to transition to these new kinds of payment systems and develop these kinds of skills. What would a transition system look like? Well, what we are doing in various places around the country, and we're doing this in Colorado, is to have medical home programs. And they can fix this by basically saying, we'll give some upfront money to the physician practice, flexible money, so that they can actually afford to give you phone calls and hire nurses and things like that. The problem with most medical home systems today is that they don't actually guarantee you that you're going to save any money on the other side. And so a lot of health plans and employers are very skeptical about whether they should invest in these things because they see more money up front, no guarantee of savings. It sounds to me like it's increasing healthcare costs. The model that a lot of health plans have been trying to put in place, and this is what Medicare is trying to pursue right now with accountable care organizations, is called shared savings. The shared savings model says if you can figure out somehow how to reduce ER visits and hospitalizations and lab tests and all that kind of stuff and save some money, we'll give you some of it back a year or two from now. So if you're a primary care practice, which have a huge bank account, obviously you just go and you draw down on your incredible reserves, hire all these nurses, etc., and then wait for the money to roll in. Well, it doesn't work that way because most doctors don't have those kinds of resources. And I'm not at all a fan of the shared savings model for a variety of reasons, one of which is that there's no upfront money because a lot of changes have to be made. They're expensive to be able to do these things. Second is it puts you accountable for everything that happens in the healthcare system. So I could be doing a great job of keeping my chronic disease patients out of the hospital, and a few of them end up with cancer. It costs a lot of money. Total money doesn't go down. I get nothing back. I suspect that the folks in Miami will be really much happier with the system than the folks in Colorado because they have much higher rates of utilization and have the potential for greater savings. But the fundamental problem with it is it doesn't actually change anything about the way the current payment system works. Everything that doesn't get paid for still doesn't get paid for. People still lose money whenever they prevent infections. So it's really not fundamental payment reform. So what could work? Well, I think that what you want to do is be able to simulate the flexibility of global payment and the accountability of it in a way that's feasible for doctors to do. So, for example, give some more money up front to the primary care physician to be able to do the things that would help, but also ask them to take some responsibility for reducing those ER visits and hospitalizations or lab tests and attach some pay-for-performance kinds of bonuses or penalties around that so that their money increases or decreases based on how well they do. This is what the state of Washington is putting in place this spring with 8 different payers, health plans and Medicaid. Primary care practice will get some upfront money to be able to do these things that are better. But they'll also agree to specific targets for reductions in preventable ER visits and hospitalizations. If they meet those targets, they'll get a bonus. If they don't meet the targets, they have to give some of the money back that they got up front. So it gives them some accountability, and it gives them an amount of financial risk that is manageable for them to do. And this is actually what the primary care practices in Washington said they wanted. They said, we can't do a pure shared savings model because we need the upfront money to be able to do this. But we're willing to take accountability if you give us something that we can take accountability for. Let me, and again, this is hard to see in green in the back of the room, but I just want to show you how the numbers work for this. So, Jay, can you see that? No? Okay, so you're my test case. So what that says is this is my hypothetical primary care practice. They have 4 doctors in the practice, they have 2,000 patients per doctor, and they get paid collectively $1.1 million by the health plan, and the doctors make $180,000 salary, sort of what a typical PCP salary company. At the same time, all of their patients are showing up at the ER at the rate of 200 per 1,000 patients. 40% of those ER visits are preventable. They're sniffles that shouldn't be in an ER, they're chronic disease exacerbations. And the health plan is paying $1,000 every time they show up at the ER. So the health plan is actually spending $640,000 on these patients. Now, suppose that the primary care practice would say, let's go hire a nurse practitioner. We'll have that person do patient education, answer the phone when patients have problems, etc. We'll spend $90,000 on that. And by doing so, we could achieve a 40% reduction in those preventable ER visits. That would save the health plan $250,000. But where's the primary care practice get the $90,000 to hire the nurse that's going to save the health plan $250,000? Well, the health plan could pay for it. The health plan could give that primary care practice the $90,000, and the health plan would still make out. They'd still save $166,000. And in fact, the health plan could say, instead of just purely covering the costs of the nurse, I'll give you an incentive. If you save us net money, we'll give you 50% of it back. So they could split that $166,000 with the primary care practice. The health plan is still spending 13% less than they were spending before on those preventable ER visits. The primary care practice is getting enough money to give their physicians a 12% salary increase. So you end up with a win-win-win. Patients are better off because they're not showing up at the ER as often. The doctor's better off. The health plan is better off. But you have to give them the money up front to be able to do it, and you have to give them a target that they can do something with. Now, this isn't just primary care practices, because the problem I have with medical home programs is great in terms of paying primary care physicians to coordinate care for their patients. So they now have the time to call up all the specialists and coordinate care. Who's paying the specialist to answer the phone when the primary care physician calls? Because specialists only get paid for office visits too. So you have to figure out how to fix the medical neighborhood as well as the medical home. Minnesota is doing a project like this they call it the Diamond Initiative, focused on depression. So they pay the primary care practice like a medical home. They give them a nurse care manager to help manage the care of patients with depression. But they also pay the psychiatrists a consulting fee to work with the primary care physicians and those nurses as a team to be able to manage those patients. And they've seen really dramatic improvements in remission rates for depression as a result. Now, if you're a hospital, any hospitals, and you're listening to this, you would say, wow, all these things he's talking about, keeping people well, keeping them out of the hospital, reducing infections is going to actually reduce the number of patients that we have. So what does this do to hospitals? How will they have to change? Well, my answer to that is that they're going to have to be smaller and higher priced. And now you're thinking, yes, he is insane because he keeps talking about higher prices all the time. What do I mean higher priced? Well, if you think about this in every other industry, what is success in every other industry in America? Success is the business sells more product. If the business sells more product, it can spread its fixed costs across more products, and it can actually sell the products then at a lower cost. If it sells them at a lower cost, it sells more product, virtuous cycle, right? The problem is in healthcare, we don't want to sell more product. We want to sell less product. So it's not that economics is different in healthcare, it's exactly the same, it just goes in the opposite direction. So if a hospital, which is a largely fixed cost institution, delivers fewer services, it's going to be more expensive on a unit basis for them to deliver the services that they still deliver. Total spending may be lower still. So let me give you an example. So if I have a hospital and I reduce the rate of admissions by, say, 20%, the hospital's costs may only go down by 7%. Because they don't eliminate everything when a patient doesn't show up there. But a health plan or Medicare will happily pay them 20% less because 20% fewer patients are going to the hospital. Now, who here can tell me what happens to a hospital whenever their revenues go down by 20%, but their costs only go down by 7%? They lose money. But what it also means is that the health plans are now actually underpaying for care. They might have been paying the right price at high volume, but they're not paying the right price at low volume. And so you can reprice the care in a way that still saves the health plan money, but doesn't put the hospital out of business. And so what's going to happen in communities around the country, again, this is a community discussion, is how do we create a feasible glide path for our hospitals? Some of our hospitals, it's not a problem. I mean, they're bulging at the seams. They would be happy to have some of these chronic disease patients out of the hospital. But for small community hospitals, huge problem. So in Pennsylvania, for example, the Geisinger Health System I talked about earlier has a medical home program. It's been so successful that some of the community hospitals in their area have seen their admissions drop by 50%, 50%. Very hard for a hospital to adapt to that quickly. So you've got to renegotiate prices. Now you also have to do this across all the payers, because if only one payer does this, if only Medicare does it, if only United does it, or whatever, what's the doctor or the hospital supposed to do with the other payers? So am I supposed to say, okay, I'll keep you from getting an infection, but I won't keep you from getting an infection. You know, I'll help you manage your chronic disease, but I won't help you. I mean, that's not the way doctors deliver care. So you've got to be able